Chemotherapy and targeted therapy for recurrent or metastatic disease, single agents. So, if patients with recurrent or metastatic head and neck cancers, they have a median survival of 6 to 11 months and a 1 year survival rate of 20 to 40% when treated with chemotherapy alone. So, although selected patients may derive apparently significant prolongation in survival, average survival improvement appears small at best. And the duration of responses is typically measured in weeks to months, not years. Survival beyond 2 years is infrequent, and cures are anecdotal. Thus, the primary intent of chemotherapy in this setting is to achieve tumor regression with the hope that the potential palliative benefit and possible modest survival improvement will outweigh the side effect of the treatment. Number of drugs have been demonstrated in clinical trials to have activity in head and neck squamous cell carcinoma, and the most commonly used include methotrexate, cisplatin, carboplatin, 5-fluorouracil, paclitaxel, and docetaxel, with reported major response rate ranging from 15 to 42%. And among other drugs with reported major response rate of 15% or greater with bleomycin, cyclophosphamide, doxorubicin, hydroxyurea, ifosfamide, irinotecan, oral uracil, and with the leucovorin, pemetrexed, vinblastine, and vinorelbine. Some of these agents, cyclophosphamide, doxorubicin, hydroxyurea, have their activity based on reported assessment in a limited number of patients from over 2 decades ago, an era when methods and criteria for response assessment may have been differed from our current standards. Anticipated response rate and toxicity profile may vary based on the patient selection and drug schedule. A poor performance status is associated with both low response rate and greater potential for toxicity. The larger the amount of prior treatment also adversely affect response rates. Methotrexate is a historical standard drug used in the recurrent or metastatic disease setting, and the typical standard dose is 40 mg per meter square IV weekly, with the dose attenuation or increase up to 60 mg per meter square based on toxicity, with mucositis being a frequent reason for dose adjustment. Cisplatin is a cornerstone drug in the modern management of head and neck cancer and is customarily dosed around 75 to 100 mg per meter square IV every 3 to 4 weeks. And the potential for renal increase in creatine electrolyte abnormalities, autological, that is high frequency hearing loss, tinnitus, neurological like peripheral neuropathy, gastrointestinal nausea, vomiting, toxicity are widely appreciated, but this risks are manageable if patients are appropriately screened for therapy, monitored closely, and stage of the art supportive care measures are applied. Although taxanes as a class have a significant activity in head and neck squamous cell carcinoma, hope for clinically significant improvement in survival in palliative setting with the introduction of these agents have yet to be realized. Docetaxel appears less neuropathic than paclitaxel, but fluid retention and hematological toxicity may be more problematic, and typical dose is 60 to 100 mg per meter square IV over 1 hour. Initial studies evaluated a bolus schedule for 5FU, an infusion program 1000 mg per meter square per day over 96 to 120 hours appears more efficacious in head and neck cancer. Infusion 5FU is associated with more mucositis and diarrhea than bolus. So the shorter infusion 96 hours is typically applied in patients who are pre-treated and have received prior head and neck RT. Cetuximab is a chimeric immunoglobulin G antibody that binds to epidermal growth factor receptor. Is the only targeted therapy in US FDA approved in the management of in the patients with head and neck cancer, given that EGFR is highly expressed in head and neck squamous cell carcinoma, and the degree of expression is inversely associated with prognosis. And there has been a keen interest in drugs that targeted the receptor itself or steps downstream. So these are all drugs, cetuximab. Combined with platinum-based therapy, median survival remained disappointing, ranging from 5.2 to 6.1 months. Although EGFR antibody zalatuximab was compared in a randomized trial to best supportive care alone in patients with cisplatin-frequent refractory squamous head and neck cancer, among 286 patients, there were no significant improvement in the primary endpoint of overall survival. The small molecule tyrosine kinase inhibitor, that is gefitinib or erlotinib, they offer no efficacy advantage similar refractory patients. Major response and median survival ranges from 5.9 to 8.1 month. When compared to methotrexate in phase 3, gefitinib did not improve survival. Panitumumab is a fully human monoclonal antibody that targets EGFR. It is longer acting compared with cetuximab and administered once every 3 weeks. So the successful development and approval of cetuximab in head and neck squamous cell cancer potential for therapies exploit specific molecular pathway with therapeutic effect. Novel therapeutic target continue to be evaluated, and PI3K-AKT mTOR signaling pathway is commonly altered 66% in head and neck cancer and has been associated with an advanced disease. A number of early trials evaluating this PI3K mTOR inhibitor had disappointing results. Preliminary efficacy has been demonstrated with the PI3K alpha isoform inhibitor alpelisib and tacelisib in selected patient with PIK3CA mutation. And of note, the novel combination of alpelisib with cetuximab and buparlisib, a pan PI3K inhibitor, in combination with paclitaxel, were found to be active in non-selected population. More recently, the farnesyl transferase inhibitor TP-farnib shown to be active in patients with HRAS mutant in head and neck cancer, recurrent metastatic head and neck cancer, which comprise only 4 to 8% of the head and neck cancer. So a number of other new agents, often with multi-target capability, have entered clinical trial. For example, there is a good rationale for agents that target angiogenesis in the head and neck squamous cell carcinoma. So cancer gene therapy, whereby genetic sequences are introduced via viral or non-viral vectors, is well suited to head and neck tumors, given the local regional character of head and neck tumors that facilitates direct injection and monitor of gene expression. And the tumor suppressor gene P53 has been one target because somatic mutation of it are common in head and neck cancer, particularly among patients who have smoked cigarette and used alcohol. Thank you.